Trans-fascial mesh fixation in retro-rectus hernia repair, the advantages and disadvantages. Welcome to today's episode where we take a closer look at the nuances of mesh placement in retro-rectus, or rivestoppa, hernia repair. This topic is at the forefront of modern surgical technique, and understanding the benefits and drawbacks of trans-fascial sutures is essential for both practitioners and patients. Let us begin with an overview of the retro-rectus repair method and mesh fixation. In this technique, the mesh is strategically placed behind the rectus abdominis muscles but in front of the posterior sheath. Such positioning harnesses intra-abdominal pressure to hold the mesh securely against the abdominal wall, a principle known as self-fixation. However, initial mechanical fixation remains crucial to prevent early mesh migration before the body's tissues have had the opportunity to grow into and secure the mesh. There are two primary strategies for mesh fixation: the use of trans-fascial sutures and the application of fibrin sealant, otherwise known as biological glue. Advantages of trans-fascial sutures. Let us first consider the advantages of trans-fascial sutures. Secure and reliable initial fixation. Trans-fascial sutures provide the strongest form of mechanical anchoring in the critical early post-operative period. These sutures physically secure the mesh to the robust anterior fascial layer, minimizing the risk of migration, folding, or buckling. Though comparative studies are somewhat limited, decades of surgical experience and extensive case series, such as those by Stoppa, Wantz, and Nowitzki, have demonstrated notably low recurrence rates when this technique is properly executed. Many surgeons regard these sutures as the benchmark for fixation in open surgical procedures. Prevention of seroma formation. By tightly apposing the mesh to the posterior sheath and underlying muscle, trans-fascial sutures effectively eliminate the dead space where fluid, or seroma, could accumulate. The reduction of dead space through mechanical opposition is a cornerstone of sound surgical practice. Promotion of tissue ingrowth. A firmly anchored mesh sitting flush against vascularized tissue enables rapid and robust cellular infiltration and collagen deposition. Histological studies consistently show that mechanical fixation leads to superior tissue integration compared to meshes left unfixed. Tactile feedback and surgical precision. Surgeons appreciate the tactile feedback that comes with passing sutures through the fascial layers. This process allows for precise tensioning of the mesh, achieving a perfectly flat and taut result, an element of control that adhesives simply cannot provide. Disadvantages of trans-fascial sutures. Despite these strengths, trans-fascial sutures do present some significant disadvantages. Chronic postoperative pain. Perhaps the most common concern is chronic pain, which can occur when sutures entrap or irritate sensory nerves running through the abdominal wall. This complication, sometimes neuropathic in nature, is well documented in the surgical literature. Increased acute postoperative pain. The act of passing and tying sutures through muscle and fascia inevitably causes trauma and inflammation. Patients often experience higher pain scores after surgery and may require more pain medication, which can delay their ability to move comfortably. Risk of ischemia and wound complications. If these sutures are tied too tightly, they can hinder blood flow and increase the likelihood of wound infection, the formation of suture sinuses, or even facial tissue death. This risk is especially pronounced in patients with underlying health conditions or in contaminated surgical cases. Technical difficulty and extended operative time. Placing trans-fascial sutures demands a high level of skill and patience. The process can be time-consuming and requires careful attention to avoid nerve entrapment, which can further elevate the risk of chronic pain. Evidence-based comparison. Sutures versus fibrin sealant. Let us now turn to the evidence. One of the most comprehensive randomized controlled trials, published by Stoics and colleagues in the journal Surgery, compared suture fixation with fibrin sealant in open ventral hernia repairs. The results were clear. Fibrin sealant led to lower pain scores both at rest and during activity. Patients in the sealant group used significantly less opioid medication and spent less time in the operating room. Importantly, at 6-month and 2-year follow-ups, there was no notable difference in recurrence rates or seroma formation between the two groups. This data suggests that while sutures may offer unmatched immediate security, biological glue provides adequate fixation for successful outcomes in retro-rectus repairs. The inherent stability of the Sablé technique reduces the necessity for strong suture fixation. Conclusion and synthesis. To summarize, the choice between trans-fascial sutures and alternative fixation methods such as fibrin sealant is ultimately a trade-off between reliability and patient comfort. Trans-fascial sutures remain the standard for initial secure fixation, particularly in complex or large hernias, but they bring with them a heightened risk of acute and chronic pain. Fibrin sealant, on the other hand, mitigates this major disadvantage and shortens operative time. Modern hernia surgery often employs a hybrid approach, a handful of sutures at strategic points combined with sealant elsewhere, blending the benefits of both techniques while minimizing their drawbacks. Thank you for joining us on this episode. We hope this deep dive has provided clarity on the intricacies of mesh fixation in retro-rectus hernia repair. Be sure to subscribe for more expert insights into surgical practice and innovation. It's the Everything Surgery Podcast. Dissect the extraordinary.